Our Crawford's going to include Hamish Crawford from New Zealand, Debbie Eastwood from London, Josh Hyman from New York, Chad Price from Orlando, and me, I'm Pablo Castañeda from Mexico City. So we're going to start the session out with Chad Price, who is going to talk to us a little bit about embryology and possible prevention of DDH.
No, I have no relevant financial conflicts of interest, nothing to disclose. This study of mechanobiology of hip joint morphogenesis was performed at the Royal College of London, and one of the principal investigators is now at a local university, so we've had some great interactions on this. And what they did was model the primitive joint cartilage after cleft, showed that multidirectional movement creates a ball and socket joint. Now, this may not sound like much, but previously we thought that the joint shape was genetically determined, and that also allowed the movement. But what this suggests is it's actually the direction of movement that creates the joint shape. So that after initial clefting, you have sort of a square joint, and then if you don't have the right joint movement, then it won't develop properly. And that may be what happens in arthrogryposis, because you have square joints in arthrogryposis because of intrauterine paralysis. So it's actually the movement that creates the shape. And they went one step farther and measured hip motion on cine MRI during fetal growth. And this is not an ultrasound, it's an MRI of an infant in the womb. And you can see that the infant kicks and moves their hips, and they measured different amounts of motion. Now, at week 22 of gestation, on the top there, you can see the baby's extended his hips, and this is a cephalic presentation. And there's 132 degrees of hip motion. But by week 34, as the fetus gets bigger, there's only 62 degrees of hip motion. So if hip motion influences joint mechanics, what happens? Well, as it turns out, greater amounts of movement in all directions create a deeper hip socket. And that may be why the hip becomes shallower near term and deepens again after birth. And this has been known for years. So at week 16, it's fairly deep, but it actually becomes shallow at birth. And that's been shown in Ladamini did some dissections of fetuses in 1923, and this has been confirmed by Rellis and McKibben in 1973, that the human hip socket is shallower at birth than at any time before or after birth. Here's an example from Rellis and McKibben that shows that at birth, the hip is the shallowest, that it's actually deep and then gets shallower, and prenatal hips that have been looked at on ultrasound are generally deeper. So it actually becomes shallow at birth. Now, this is an example of a cross-section of a 12-week human embryo after clefting and initial joint formation. You can see the depth of the socket compared to a 2-month-old infant, where the acetabulum only encompasses about a third of the femoral head. Now, by 1 year of age, there's been a rapid development in the depth of the acetabulum, and that continues till about 5 years of age when it plateaus. But as we know, that first year is most important, and that's when the hip is going from a shallow to a slightly deeper position. So it's not just about bony maturation, it's about depth of the socket. In fact, this study by Peter Cundy and the group in Australia looked at the average alpha angle at birth, and we think less than 60 is abnormal, but that's because it's more than 2 standard deviations from the mean. The mean is 70 degrees. By 6 weeks, the mean is 76 degrees, and by 3 months, the mean is 80 degrees. So if you look at 3 months, an acetabular alpha angle of 70 or 60 is fairly far outside the mean. There's 60 by 3 months. More modeling by Dr. Carrero, who's here in Central Florida, looked specifically at the hip. And what they found was that dynamic hydrostatic pressure, like during dynamic movement with tensile stress, promotes cartilage growth. So this is kind of what Salter said with continuous passive motion stimulates joint cartilage formation. But static pressure, by the Hooter-Volkmann law, static pressure inhibits endochondral bone growth. So that if you put the hip in an abduction brace and hold it in that position, then what happens is that it inhibits the growth in the center of the acetabulum, because that's where the pressure is, but allows growth at the periphery. So that's the mechanism by which bracing works after surgery, but dynamic motion works during the primitive cartilage formation. The femoral head is centered in the acetabulum at 90 degrees of flexion and 60 degrees of abduction, and the muscle action of the infant's thighs in this position actually improves acetabular development because the femoral head is pressed against the center of the acetabulum. And a Professor von Ewald-Fettweis, actually prior to 1991, but he wrote a book in 1991 that showed that these active muscle forces in a squat position on the mother's body, as in infant carrying, promotes acetabular development. And he had some biomechanical models which were also confirmed by another German, Buschelberger, that showed that this position is ideal for deepening the acetabulum. And that brings us to the current concept of contact parenting. And some of you may not have heard of this, but it's a big movement now. It's probably going to be very important. More time on the mother's body seems to promote social emotional development, cognitive development, and emotional resilience later in life. And I think this may become as important as prepared childbirth, breastfeeding, and swaddling as an infant practice, so that mothers are now being encouraged to carry their babies longer, and it may be a way to get moms back to work with their babies worn. When the babies are worn, they don't cry as much, they don't fuss as much, and if you have a clerk who wants to bring her baby to work, say that's fine, but don't put them in a bassinet and put them beside you. We want them on your body so they're quiet. And we know that back pairing in infants has been proposed to prevent developmental hip dysplasia in certain countries. We haven't proven the association between this infant carrying position, but it's true that cultures that carry their infants in this position have very low prevalence of hip dysplasia and very low prevalence of adult hip arthritis. Some of that's genetic, but some of it may be cultural. So in summary, what do we know? We know the hips are shallowest at birth, and that rapid hip development occurs in the first 6 months of life. The tight swaddling position is bad for hip development, and the spread squat position is optimum for hip development. Thank you very much.
I'd like to ask Chad to come back and talk to us about an imaging review in a case-based manner.
I hope that we'll see pediatricians adding ultrasound as a diagnostic assist without referring them to radiology. This is an imaging review. Much of it hopefully is a review for you, but we need to have some content for case discussions. There are several methods of ultrasonography for interpretation, the graph, the Harkey, and several others that you may or may not be familiar with. I'm just going to review the top two. The graph method is a static measurement, and as you know, a bigger alpha angle is better. And the alpha angle is, basically this is a view of the AP X-ray of the pelvis if you look at it. And so the alpha angle measures the bony pelvis with the ilium here and the acetabular roof. But what happens on the ultrasonographic view is it's turned sideways. Just like if you took a video camera and turned it sideways and then watched it on TV, you'd be looking at everything sideways. So you have to turn your head sideways, and that's where the alpha angle is. So if you look at the alpha angle in the coronal view in this position, then the alpha angle is measured here. And these are different degrees of alpha angle. This would be a normal one that's 70 degrees. And then this one doesn't quite show up, but it's about 35 degrees. And this one's about, I'm sorry, I can't read the numbers. Somehow they change colors on me. But that's about 43 or 44 degrees, and then this one's 30 degrees. So the increasing amount of dysplasia correlates with the alpha angle. The graph treatment based on the alpha angle is the 1A is less than 3 months old, and it's 50 to 60 degrees. The 1B is 50 to 60 degrees older than 3 months old. Now I would suggest that maybe that should drop down to 6 weeks, because like Kundi said, that 60 degrees at 6 weeks is still pretty abnormal. There's a 2A minus, which is 50 to 55 degrees, and there's recent literature that suggests that the 2A minus should be treated with a Pavlik. So basically, if it's less than 55 degrees, it should be treated, and if it's less than 60 degrees at 3 months of age, it should be treated. As we said, here it is from the angle. Even at 6 weeks, the average alpha angle is 76, and 60 is outside the range of 2 standard deviations. The Harkey method is dynamic and it reproduces the Barlow test. So this is basically a reproduction of the Barlow test with stress, and it can be measured. This is a coronal view. We'll discuss that in a minute, but it's reported as percentage coverage with and without pressure, and you can see that with pressure, without pressure at rest, this is about 50%, and it goes down to about 35% coverage with pressure. So the hip moves away from the medial acetabular wall. And better than 50% coverage is considered normal. 35 to 50 is moderate subluxation. Less than 35% is severe subluxation, and there's dislocated. This is the transverse view, where the wand is turned vertically, so you're looking at a transverse view of the hip, and you press down on the baby's hip to see if it's unstable. So you're looking at the hip like this with the femoral head. Here's the femoral head. This dark piece is the shaft, and this is the growth plate. So this is the growth plate, the femoral head, the trochanter. You can see all these things. Again, because of the projection on your video screen, it's turned in this direction, so that you're actually looking at this transverse view sideways. And once you understand that this is the acetabulum and this is the femoral head, here's the labrum right here, and that's the posterior wall of the acetabulum. This is the growth plate of the femur. So in the transverse view, which is Harkey's method and the preferred method now by most people that are using it, the newborns may have 4 to 6 millimeters of instability, but the treatment indications at birth, if you see a dislocated hip, then you're going to treat it. But at 3 weeks, if there's subluxation present, then you would treat it. But at 6 weeks, if there's any instability after 6 weeks, 3 to 4 millimeters is not normal after 6 weeks. And then you would continue treatment until stable. So this is basically an assist to your clinical diagnosis. Now, radiographic imaging, we're all familiar with how to make the diagnosis on an AP X-ray, but there's some discussion about how we follow the child. The acetabular index is reliable, plus or minus 5 degrees on an AP radiograph of the pelvis. But you must have an AP radiograph of the pelvis. And Tonus defined some of these things like the obturator ratio, which is the width to height, and this is called the inclination angle. The inclination angle needs to be 95 to 130 degrees. And in my practice, I don't measure these, but I make sure that I'm looking at a pretty good symmetrical view of the obturator foramina and a good AP X-ray of the pelvis. Some people feel that this pelvic view is better on the frog lateral because it stabilizes the pelvis than it is on an AP, but there's a study in progress right now to see if that's more reliable. So right now you just want a good AP and measure the acetabular index. Now the acetabular index, it's been said that the upper limit of normal at 1 year is 30 and at 2 years is 25 degrees. And that may or may not be true, but if you look at this, the upper limit of normal at 30 degrees, here's 1 year, this line is 1 year, and you can see this is more than 2 standard deviations from the mean. And at 2 years, 25 degrees is more than 2 standard deviations from the mean. So if you're accepting these as normal, it's a defined normal, and it's pretty far out there. 2 standard deviations from the mean is pretty far. In fact, 2 standard deviations from the mean for an IQ would be 70. And 2 standard deviations from the mean from adult height is 5 feet 4 inches for a male, or 1.63 meters. And while that may be acceptable, and it is normal, I think for mechanics of the hip joint, we probably want to try to get the hip better to the mean than to an arbitrarily defined normal of 2 standard deviations from the mean. So it seems to me that our target number should be closer to the mean. And the mean at 7 months is 22 degrees, and the mean at 2 years is 18 degrees. So if you see an acetabular index of 30 degrees at 7 months, you're 2 standard deviations from the mean. And I think I've become a lot more aggressive with a little longer term bracing when I see an acetabular angle of 30 degrees even in a 6 or 7 month old. So a more cautious approach with prolonged bracing may be appropriate for an acetabular index of 30 degrees, and maybe 24 degrees at 24 months is still way too high. It should be about 18 degrees. Thanks.
Thanks, Chad. That was fantastic and a great segue into the next talk, which is going to be, I'm going to provide this, which is the technique of infant ultrasound as performed by the clinician. And this is actually video which is available on YouTube, and if you want to feel a little bit more scientific, it's also available on VuMedi. But the objectives are to prove that ultrasound is actually very easy to perform by the clinician. You don't need to send this out to a radiologist. It's reproducible and it's necessary. So it's necessary because we continue to see this. And the highest incidence of simple dysplasia is seen in the adult population. So if you believe this study out of Norway where they did a 50-year follow-up, which is probably one of the only places in the world where you could do a 50-year follow-up, they found that in fact the only patients who were completely normal were the ones who were treated before the age of 4 months with orthotic treatment. After that, everyone was slightly abnormal. So physical exam is unable to detect dysplasia, and radiographs like that are unable to detect instability. First question I hear with ultrasound is, I don't understand what I'm looking at. But if you can understand an AP view of an infant hip, you can understand an ultrasound. As Chad said, we do like looking at it on its side, but you can see the structures on the left with the X-ray, and it's exactly the same on the ultrasound with much higher definition. So this is actually an entire patient encounter, and you can see that in the time it takes us to uncover the child enough to do the ultrasound, we can take a short history and do a physical exam. We like to leave the baby on top of their own blanket so they're on a comfortable, cover the necessary part, do a short physical, and in this time we've already inquired as to the family history. So you take the transducer in the left hand to evaluate the right hip, and the right hand holds the leg, and you can see how by holding it parallel to the femur you obtain this transverse view, and within a couple of seconds you can determine whether the head is actually reduced, subluxed, or dislocated. Then you turn the transducer 90 degrees on its axis and come from behind, and you can obtain a coronal view which allows you to evaluate the morphology of the hip and determine whether it's dysplastic. So for the left hip, left hand holds the leg, right hand holds the transducer. You can see it's parallel to the femur, and you can see the view on the screen, which is showing a located femoral head. Then the transducer is turned 90 degrees, and you obtain a coronal view where you can see the morphology, the acetabulum on the left and the femoral head on the right. Now I'll go through these numbers a little bit more, but for stable dysplasia, this is the most specific test you can do. So there's 3 degrees of pathology: stable dysplasia, instability, and dislocation. And we've said that you can't pick up on instability by X-ray, but you can do it on ultrasound. And you can see this is a femoral head on this side, and you can see how it's coming out the back. And this is actually not, you're not able to feel this on physical exam unless you have about 7 or 8 millimeters of displacement, which is much more than would be considered normal. You won't feel that coming out the back. Again, this is the view. Chad showed this very nicely. Transducer is on the lateral part of the leg, and the buttock would be on to the right of the screen. And that's the image you obtain with the proximal femur, the acetabulum. You can see the posterior labrum, and that's where you can evaluate the dynamic component. You don't need to measure angles. That's something which radiologists do, but in the beginning you need to between the ileum and the bony acetabulum. It should measure at least 60 degrees. Beta angle is between that line and the cartilaginous cover. You can do an ultrasound with a Pavlik harness on. It actually is even easier because the hip's held for you. And ultrasound will provide you guidelines to start treatment in any abnormal hip, whether it's stable dysplasia, instability, or dislocation, whether it's reducible or not. And we can discuss amongst the panel how long you would leave an unreduced hip out. It will also provide you guidelines on when to stop treatment, which is basically a hip that hasn't reduced, for me, within about 3 weeks, or if you have a serious complication like a femoral nerve palsy. My guideline is generally to treat until the hip is completely normal on ultrasound, and once you get past about 6 months, I do get an X-ray, and I would continue bracing, as Chad said, until you have it completely normal. And for me, normal does mean you have to be within 1 standard deviation for the age. So in conclusion, this is actually an 8-second test. It doesn't take longer than that. This is quicker than any X-ray in any hospital, which is safe. There is no radiation involved, and it will give you a definitive answer as to what the status of that hip is. So just quickly, as we look at this, the sensitivity of these 3 tests, physical exam, which Josh outlined, a plain radiograph, are almost completely unable to detect stable dysplasia in an infant less than 4 months. So according to Norway, if you want to treat these and have completely normal hips, you need to do screening by ultrasound. For unstable dysplasia, physical exam is good. It's better than plain radiographs, but you'll still be missing 83 out of 100 hips because you won't feel a truly Barlow positive hip unless you have at least 7 or 8 millimeters of displacement, and we know from ultrasound that about more than 3 or 4 millimeters is abnormal. And for dislocation, X-ray is better, but ultrasound is still the highest quality as far as the sensitivity of a diagnostic test for detecting it. You can see these hips, the one on the left is reduced, and by producing slight pressure you can see how it's coming away, and this is actually an unstable hip which you can't feel clinically. So if you like classification systems, and we're orthopedic surgeons, you can use the graph classification. This is purposely left as a very busy slide because people who have trained with me know that I can't deal with classification systems of more than 3 degrees. So we came up with a more simple classification, which is basically the pathology. You can have a grade 1 dysplasia, grade 2 instability, and grade 3 is a dislocation. My partners actually said this was a way too complicated classification. So in true orthopedic style, we modified this now. And this is our current classification system where a hip is either classified as normal or abnormal. And when you're in clinic, that's all you need to know. Does this hip need treatment or can I leave it? In summary, it's a low cost, no radiation, easy to perform, easy to learn how to do. So I would push that everyone starts doing this. It will provide guidelines on when to start treatment, when to stop treatment, and also identifying risks. So thank you very much. And our next speaker will be Hamish Crawford from Starship Hospital in Auckland, New Zealand, who's going to talk about the Pavlik harness, indications and technique.
Thanks, Pablo. I have no disclosures except that I learned a lot about DDH from these two great mentors, Stu Weinstein and Dr. Ponsetti, when I was in Iowa in 1998. We're not going to talk about abduction braces, but there's many ways to hold a hip apart from Pavlik harness. But in this talk, we're purely going to talk about the use of the Pavlik harness. Pavlik said back in 1957 that the main aim of the treatment is to achieve a concentric reduction and to prevent avascular necrosis, which cripples the child for the whole of his life. In this talk, we'll cover patient selection, the application of the cast, and how I supervise a Pavlik harness once I've applied it. Patient selection is crucial. And I divide this up into 4 different types. There's the dysplastic hip, the dislocatable hip, the reducible hip, and the irreducible hip. It should only be used in children less than 6 months old, but personally I use it really more in younger patients, probably under 4 months of age. The problem with the results of looking at Pavlik harness use and other things is the success rate has a huge variation, and the AVN rate has a huge variation because we tend to lump all those 4 previous conditions all into one when we look at the results. So what I'd like to do in this talk is look at the different types of treatment for each one of those 4 categories. Importantly, there are contraindications to using the Pavlik harness. It should not be used with severe muscle imbalance and cerebral palsy and myelodysplasia, in patients with excessive ligamentous laxity, for example, Ehlers-Danlos syndrome, or when there's significant joint stiffness, arthrogryposis. The Pavlik harness holds a dysplastic hip reduced. It holds an unstable hip reduced if it's Barlow positive or Ortolani positive, and it may, and I say may, help reduce a dislocated hip. In my hands, the surgeon supervises putting the Pavlik harness on. It is placed against the skin. It's the correct size, which is crucial, and the hip is put into the position which is stable. So you don't leave this for someone else to put on. You need to put the hip on, the harness on yourself, and supervise that when you've finished putting it on, the hip is stable. And you need to mark the straps and put tape around them so no one can tamper with them. And I refer you to Dr. Mubarak's great article in the American Journal for the pitfalls in the use of the Pavlik harness. Here's one that I've applied. The foot sits down nicely in the straps. There's plenty of support around the lower leg. The hip is flexed over 90 degrees. There's still some room for further abduction. The chest strap is at nipple height, and I can just get my hand under that chest strap so it's firm but not too tight. My rules are that the Pavlik harness is never taken off by the parents or anyone else. They have to sponge bath the baby, and they're not allowed to put anything in the groin crease to prevent femoral nerve palsy. I personally supervise the Pavlik harness by seeing the patient weekly until the hip is stabilized. I use a clinical examination on each visit, and in difficult cases, especially the Ortolani positive ones, I use ultrasound. I keep them in the pelvic harness for a further 6 weeks after stabilization has occurred, and I personally don't use a brace or weaning after the harness, which I'm going to change. I'm going to change that because I've been made aware more recently of late acetabular dysplasia, and this was really well put together by Dr. Mubarak a couple of days ago, who said he braces until radiologically normal. I think we've heard already this morning from Dr. Price that he certainly is bracing people longer. So some food for thought. I think you really need to follow the patients until skeletal maturity. You need to use the pelvic harness for longer than 6 weeks after hip stability. And I think you really need to have a weaning protocol or brace protocol for all patients for a longer term bracing, or perhaps at least in selective patients or older patients that you're using the pelvic for. With regards to ultrasound, I personally do not ultrasound the patients myself, but I do get involved, as in this picture, when I have a difficult patient that I want to go and observe it for myself. It does confirm or reassure your clinical impression. I think it's very useful to show the parents and yourself that there's clinical improvement. And as Dr. Price has shown, you can use it for selecting some patients for pelvic harness use. Here's a dysplasia example. The head very subluxed, was treated in a pelvic harness, and you can see this patient had excellent result 4 years later. Franz Grill and the EPOS study group looked at their dysplastic patients in thousands of patients in Europe and found a 95% success rate just treating hip dysplasia with a pelvic harness. However, if you look at Wood in the Journal of Pediatrics in a randomized controlled trial looking at the treatment of dysplasia in the pelvic harness, he saw no difference between the two groups. So again, the treatment of just dysplasia by the pelvic harness remains, I think, somewhat controversial and has been defined better. In terms of the Barlow positive hip, the hip that we can dislocate but is in joint when you examine it, very successful with only about a 7% failure rate in most people's hands. The Ortolani positive hip, the hip that is dislocated when you examine it but you can reduce, in my mind, is a different beast from a Barlow positive hip. My personal failure rate is higher, and you can see in Lerman's group there's a 36% failure rate with a pelvic harness in this group. Here's an example of a failed Ortolani positive hip where the hip is dislocated on the left, the right side is normal. It was held dislocated in the pelvic harness, so developed pelvic harness disease. The surgeon looking after this patient changed course and used a rigid brace. The hip remained dislocated and went on to have an open reduction. So an Ortolani positive hip, what I do is I have more meticulous pelvic application. I put the affected hip in a relatively extreme position, but I readjust that weekly to a safer position, and I definitely use ultrasound surveillance in doing this. And if it's not working after 2 to 3 weeks, and more recently even after 1 to 2 weeks, I stop and try a different treatment or try a closed reduction later on. I rarely use the pelvic harness in an irreducible hip. I think the failure rate is extremely high, so I don't do that. If you get pelvic harness disease, so you've held the hip dislocated and you get a deficient posterior acetabular wall, wait quite a considerable amount of time before proceeding with your closed reduction. The failure of treatment is due to poor patient selection, persistence of inadequate treatment, and a poor pelvic harness, or the patient's not compliant with treatment. Don't forget, in a bilateral dislocated hip, there may be a neurological cause and this tethered cord in this patient. So in summary, pelvic harness is an excellent device for treating DDH. You need attention to detail in using it, and the best results are if you use it early, Barlow positive hips, and if it stabilizes early. The Ortolani positive hip is a different beast. Thanks.
Don't go away, Thanks very much, Hamish. Fantastic talk. And I'd like to ask Hamish to stay up here, and Debbie is also going to be involved in this. We're going to start to do some cases. You can stay down there if you like for now, but if you'd like to come up, that would be fantastic. So let's do some cases, and I'll just quickly ask while we do this, first of all, Hamish, how long can you leave a hip dislocated with a pelvic harness? How long do you wait to see if it reduces? Can we have the cases one up, Dale? Thanks.
I don't think you should leave it more than 1 to 2 weeks.
2 weeks. So if it doesn't reduce in 2 weeks.
If I haven't got a reduction in 2 weeks, I won't persist with the pelvic harness.
And you're away on a worldwide trip. It takes 3 weeks to get back to New Zealand.
Well, then I'll kill the person who's looking after them if they've left it in the pelvic harness.
Panel, can I get some consensus? How long would you leave a pelvic harness on with a dislocated hip which isn't going in?
I think that's a little quick because most of them go in within 2 weeks. There's no question, but there are some that go in later, and I think it's perfectly safe to wait 3 weeks. Woody Sankar's been looking at pelvic harness disease, and it may also be a function of age. There's a study from Finland. They are using it in the grade 3 dislocations in children after 6 months. So in an older child, I think you can leave it on longer. You can leave it on 6 weeks to see if there's any problem. But in a newborn, it might be 3 weeks.
Debbie?
I bail out early after a couple of weeks. There was a paper presented recently, I'm hopeless at remembering, but they suggested that if you failed to start off with, that you should take the baby out of the harness, leave it for 6 weeks, and then reapply the harness. And they actually had a very good sort of success rate, a better success rate at the second attempt, which I thought was novel, and I haven't tried that yet.
Has anyone else had that? I've never had that happen.
We've had, Jose's had that happen once, where he took them out and tried it again.
Okay, so let's get to a first case here. This is a newborn boy with a left hip ortolani positive at birth who was placed in a Pavlik harness in the nursery. So first question, maybe Josh, do we need to do an ultrasound? Does he need to screen this? He was clinically positive ortolani left hip.
I think this is newborn day of life 1, I presume.
Yeah.
A positive physical exam finding. No, I think putting him in a Pavlik harness is sufficient. I wouldn't get it beforehand. Afterwards, I like to get an ultrasound just to document that the hip is in.
Yeah, I agree. I think you do need to get one, both sides. Chad, would you like to comment on this ultrasound?
Sure, but also, I didn't used to do that, but now I've really become an advocate for getting it before you treat the patient. And I think in Europe, you find that if it's a severe graft type 4, then it's a good time to tell the parents that this is probably not going to work. So it's good prognostic information. This one, it looks pretty severe on both sides, left and right. Both are dislocated. So.
And Hamish, how about putting Pavlik harnesses on in the nursery? Do you think that's a good practice, or is it probably best to wait and have them come to do an ultrasound and you do it in your clinic?
So I don't put it in the nursery. I get them to come to the clinic, so that could be 2 days or 5 days to come to the clinic. I get an ultrasound once. I put the Pavlik harness on because I want to confirm that my Pavlik's holding the hip reduced, and I also want a baseline on which, because for this type of hip, I do monitor the hip sequentially, so I want to see the dysplasia improving.
If I can make one more comment on one other thing that's convinced us is we now have 2 children who were ortolani positive on one side and totally normal on the other side, to everybody's exam, hospitalist, pediatric orthopedist fellow, everybody. And when we did bilateral ultrasounds as a part of our normal routine part of treatment, we found that the child had both hips dislocated. So.
Yeah, I think you should be doing ultrasound. Again, I mean, there's many reasons. Baseline is one of them. You can find these sorts of abnormal hips on the other side. But I don't think it's a good idea putting on a Pavlik harness in the nursery. I think it probably makes things worse sometimes, just from a compliance standpoint. Parents are going home with a newborn baby, adding the extra stress of having a Pavlik harness on from the nursery, for me, doesn't make a huge amount of difference. If they come back within a week, I think their success rate is good enough. So I don't think we need to be pushing to have Pavlik harnesses on in the nursery. When would you follow this up? This is ortolani positive, and this is in the Pavlik harness already. It's come out of the nursery, and this is 3 weeks old. Any comments on that, Hamish? Is that looking good?
So I personally would follow an ortolani hip every week until it's stabilized. It's looking like it's improving, so 50% coverage, so I'd be feeling pretty happy at this stage, yeah.
Yeah, so
usually with these, as I say, with the ortolani positive hips, I've often got them in slightly more flexion and abduction than I would perhaps a Barlow positive hip. So often at a week or 2 weeks, if I've got this in a slightly more extreme position than what we normally put in, I'd be bringing it down a bit at this stage if I had stability, if I had clinical stability as well as these findings. Yeah.
Yeah. So it's a clinically stable. How long are you going to brace this? This is 3 months X-ray and an 8-month X-ray. Debbie?
I don't brace for long, because if I have improved anatomy and improved stability on ultrasound, so if my hip has acceptable alpha measurements, alpha angle, and is ultrasonographically stable, then I followed the paper out of Oxford, and I don't think that treating stable dysplasia with a harness is the right way to go. But having said that, I've learned a lot this last day or two, so maybe I'll reevaluate my program.
So at 8 months, 23 and 20 degrees for an acetabular index.
I think that's correct.
Weaning, do you wean?
I'm an all or none sort of person, so I don't wean.
Well, mother had DDH, which was treated surgically. Some people would say that's enough to put her in a Pavlik harness without a physical exam or even doing an ultrasound. She was breached during gestation, but not at a 37-week elective C-section and a normal bilateral hip exam. This is the ultrasound, the original ultrasound. Alpha angle of 51 and a 46% coverage with pressure. So normal exam, but breach during gestation. How should we be following this up? Josh?
I would argue that this is not a normal ultrasound. The patient has two risk factors. She was breached, has a family history, and this is one I would treat.
Okay, so this is a transverse view sequence, and it actually was fairly stable, but I would agree completely this is not a normal. This in my classification is an abnormal hip, so this requires treatment. So this goes into a brace, and you can see that it was actually stable. So I think we know from the papers we've seen about this, there is this question which you brought up about hips which are clinically normal and are called ultrasonographically normal. But I think we do need to define what that is, because I think sometimes they're called normal and we wouldn't call these necessarily normal. And Sukato and Seamus, you want to make a comment?
So I'd say that's more of a North American approach than a lot of other places in the world. I think someone who's got risk factors but a normal examination, especially in a lot of our practice where we didn't use ultrasound for a long time, we would just see that patient back at 5 months of age and get a plain X-ray of the pelvis to look for any dysplasia or not. And we've personally been very happy with that approach. So, I mean, that's supported by that randomized trial and supported by some other literature in terms of treating dysplasia. So I don't disagree with that as treatment. I'm just not, and it may be risk adverse to do that, but I'm not sure in all countries that putting a pelvic harness on everyone just with risk factors is absolutely necessary.
Okay, good point. But why not put a Pavlik harness on? Is there any downside to putting a Pavlik harness on a hip which is mildly abnormal?
Well, I've never seen a paper treating dysplasia alone with a pelvic harness which has a 100% success rate and no evidence of growth disturbance of the proximal femur or any other complication.
For pure dysplasia?
Correct.
Well, that's been our results.
Can I comment on that?
Yes.
On that paper? And these papers that look at treating mild dysplasia in the pelvic harness, they've defined success, as this one did, as how many patients were normal. And I would submit that the term normal is a subjective term, because it's what we were talking about earlier. They define normal as 2 standard deviations. The way these should be reported in the literature henceforth is what was the average, median, and range of acetabular index, so that we can compare it to tonus levels, so we can see if they're approaching the normal range, not something arbitrarily defined as normal.
Right. Okay, show of hands in the audience who would treat mild dysplasia in an otherwise normal findings. So most people would treat or wouldn't treat. Just lift up, raise your hands. No downside to treating it, that's what I would think. For stable dysplasia, we've never had AVN and we've never had any femoral nerve palsy, so I don't think there is any reason not to. So I'm going to ask the panel to stay up while we continue with this. In the interest of time, we do still have 40 minutes, but we have a number of cases and still a number of talks I'd like to get to. So Dale, if we could have the DDH presentation up again. It's number 4, IPOS. And what we'll go on to now is what we actually do if the Pavlik harness fails. And I will present that, if we could pick up where we were on that last talk. Okay, so what to do if the Pavlik actually does fail. So the first thing you need to know is what your experience is. So this is my experience. We did a retrospective review of 307 patients with DDH treated with a Pavlik. Mean age at the start of treatment was 3.1 months, and the minimum follow-up was 2 years. So the diagnosis was dysplasia for 66, and all of those ended up severing 1s or 2s, no growth disturbances, and pretty normal-looking hips. Instability in 97 and 92 of those ended up looking very good, and dislocation 144 hips, 78 ended up looking good. So our success rate for dysplasia is 100%, Hamish. Instability, 95%, and dislocation, it was only 54%. That does mean that we have a failure rate of 0% for dysplasia, 5% for instability, and 46% for dislocation. So that got us thinking, why do these actually fail? What's actually going on? And you need to look at the modes of failure when you're using a Pavlik harness. So I think there's 3 main modes of failure: failure in the reduction, failure to develop the acetabulum, and the presence of avascular necrosis. So now, what are the causes of failure? The most common cause is poor use, and that generally comes from poor understanding. But that can be from parental or, more commonly, physician malunderstanding of the Pavlik harness. I couldn't agree more with Hamish. This is something you need to do. It's surprising the amount of times I get a prescription written to a patient which says Pavlik harness, and they go to some poor orthotic place, which if they're lucky, they'll know how to use it. But most times they don't, so they just come with a Pavlik harness placed in some very, very crazy ways. So that's the main cause of failure. Skin breakdown is fairly common. We do see dermatitis, but this isn't a reason to remove the harness. This can generally be treated very easily. So this is one of the reasons why the Pavlik harness fails. The parents see this, or the grandparents, and take it off. So you need to insist, and this is another reason why bringing these patients back every 2 weeks to clinic makes it an engaging thing to do. So failure to reduce, if we looked at this, 16% of our dislocated hips just didn't reduce. And we've looked at the age at the start of treatment. The ones who did well had an average of 1.08 months of age. And the ones who didn't reduce were significantly higher. So the threshold for trying to reduce a hip has gone down in our hands. And I would say that above 4 months, I'm reluctant to try a Pavlik harness. There isn't really any other great option, so I might try it, but my threshold for leaving it has gone down. So now that we've identified that it's failed, we need to think of what we can do. So there's either alternate bracing, or you can consider a reduction. And whether it's closed or open, we can get into that a little bit more. Hamish is going to talk about that. For me, the concept of the Pavlik harness is a dynamic closed reduction. So if that failed, you're most likely going to fail with a closed reduction as well. So if you look at the outcomes for these, you need to know what the need for subsequent surgery is and what the rate of AVN was after a failed Pavlik harness. And there's the 3 options: closed reduction, open reduction, or delayed open reduction, and some form of pelvic osteotomy. So if you compare those 3, the need for subsequent surgery after a closed reduction was 50%. Half of these patients are going to have some form of subsequent surgery, most commonly a pelvic osteotomy. And the AVN rate for us with a closed reduction was 15%. For open reduction alone, the need for subsequent surgery was 42%, and the AVN rate was slightly higher, 18%. And when we delayed this and did an open reduction and an osteotomy, the need for subsequent surgery went way down to 19%, and the AVN rate was only 13%. So based on that, when the Pavlik harness fails for us, the preferred treatment is delayed open reduction and osteotomy. So I'll present this case. This is a 6-month-old who's been in a harness for 4 weeks, and I'll ask the panel. You can evidently see there's dysplasia on the image on the left, which is the right hip. So this has been 4 weeks in. This hip is actually in the joint, you can see there, but it's severely dysplastic, and it's been in for a week. So how long can we leave this in? Debbie?
I would want to see progression. So if you're telling me that this is better than the last week ultrasound, then I would continue for a little while longer. But if we're not winning, then I would have given up.
So we're not winning?
No, so I'd give up.
Give up. And that's actually the x-ray you see here. The hip actually just dislocated when you took it off, and you actually have some pretty bad dysplasia on the other side, which didn't actually appear to be quite that bad on the ultrasound. So this was once it was out of the harness, and this is 6 months of age. So could I ask the panel what you would do here? Chad?
Well, this is a very anteverted hip. We got some biomechanical study from our model that shows that that anteversion actually makes it more difficult to reduce the hip. So the ones that you end up operating on tend to have more anteversion. I had an opportunity to look at the ortolani collection in Padua, and in the newborn period, there's a normal spectrum of anteversion in these kids with dislocated hips, but the failures select the more anteverted patients. So you often have to do so this one for me would be an open reduction anterior innominate osteotomy and a femoral osteotomy with derotation and varus.
So this was actually in the harness for about 6 weeks before this was done. Do you think there's any effect on the proximal femur from the Pavlik? We talked about Pavlik harness disease affecting the acetabulum. Do you think that could have caused any change in that femur?
I think that'd be hard to say. The femur gets a little bit misshapen because of it's out of the joint, but if you put it in the joint, it should be okay. You did a closed reduction.
So we did do a closed reduction. My protocol is take these to the exam room. Sometimes I think that when the Pavlik harness fails, it can be parental misunderstanding, and sometimes they'll put them in the Pavlik harness and put them in the car seat, and you'll just see the hip dislocate as they put them in. So for me, one of the indications of a closed reduction is a hip which can go in gently under anesthesia, with or without an arthrogram. I don't do them, but then put them in a closed reduction. After a closed reduction, this is a 2-year follow-up.
It's pretty good.
Yeah. Having said that, I don't do very many closed reductions. But what would you do with this one? 11 months, and she's been in a harness for 8 weeks. And this is the x-ray, so it failed. The hip didn't go in. There's dysplasia. There's anteversion. Hamish?
So I think when you get to this age, I would do exactly what Dr. Price said. I would leave this hip out. I think one is because if I was even contemplating a closed procedure or open procedure, there'll be a deficient posterior wall from being in a harness that length of time. So you're not going to operate on this hip anyway if you're going to choose something else for a couple of months, for at least the length of time it's been in a harness. So I personally would wait to an anterior open reduction at around 15 to 18 months of age, do a pelvic osteotomy, and it looks like there's excessive anteversion as well. I'd do a derotational osteotomy of the femur at the same time.
Okay, Josh, when's the ideal time to treat a hip is before 4 months. After that, when would you prefer to have a hip come in?
So I've found early in my practice that doing a successful closed reduction, satisfactory closed reduction, was one of the most difficult things in my hands. To get the hip in, know that it's in, keep it in, and then successfully treat it to complete the casting. I've been very compelled by Nick Price's data, his thoughts and then your data you just presented, that maybe we are better off leaving these hips out and addressing it with an open reduction. Some people advocate medial open reduction. I, like Hamish, like to go anteriorly. I do think that operating on the acetabulum, getting a deeper socket, a better roof for stability, and shortening the femur, and maybe doing that youngest would be at about 16, 18 months.
Okay, so this patient was actually taken to the OR. Closed reduction was attempted, and we couldn't obtain a concentric reduction, so we decided to do an open reduction.
That looks pretty, oh, that's after open.
Yes, that's open reduction.
That looks pretty good.
That's a good-looking acetabulum.
No, that's open reduction, and we actually did cut the pelvis just on the outer side.
Can I make a comment, though? I think although some of us are leaning more toward late, and I should have prefaced mine too, that 15 to 18 months delay, but I think although some of us are leaning more toward that, the standard of care is still closed reduction for the kids under 18 months, and we do closed reductions. It's just that if you go to the OR, to me that arthrogram really has to be pretty normal and pretty stable so that you can be sure you're going to get a good long-term result. If it's anything that looks a little bit bad, then those are the ones we postpone.
Here's a question. When you do a closed reduction, do you routinely do an adductor tenotomy?
I don't.
Yes. You do?
Yeah.
And you don't?
I don't. I do a closed reduction, and then I feel my zone of safety. If it's a tight hip, then I'll do an adductor tenotomy, and then I'll see the flexion, and I don't always take off the psoas. So I would say that about 1 in 2 I do an adductor, and about 1 in 3 or 4 I do a psoas.
And Debbie and I would do a adductor and psoas every time.
Well, with that then, this is the actual follow-up on this hip. I'll ask Debbie to talk on casting indications and technique.
Great, thank you. I do have no disclosures, but as always, I am biased. I work in the Catterall unit, and I do believe in our closed reduction protocol. I have been influenced by the man himself, Tony Catterall, and of course by others such as Jim Wright, so that surgery is both an art and a science, and I think that's very appropriate in the management of a closed reduction of DDH. So my indications, like yours, for a closed reduction are a subluxed or dislocated hip, defined by where the presence of the femoral head, or perhaps the midpoint of the metaphysis, is in relationship to the acetabulum. And I use the classification system of the International Hip Dysplasia Institute. And this is a hip that has been failed by conservative means to obtain a reduction, or in which I've been unable to maintain a reduction. But that's the imaging, and I should go back to the history and the examination. As we've already heard, it's important to know what has happened to that hip before you're contemplating any surgical procedure. And you look at the imaging, particularly the plain X-rays, to identify the problem. Is it unilateral or bilateral? And are these hips all the same? Where is the cartilaginous femoral head? Where is the ossification center within that cartilaginous head? And what shape do we think the bony and or the cartilaginous acetabulum are? So we're going to go behind the X-ray and remember the pathology and think about what age and stage of development that we're at. And are we looking at plasticity of a growing skeleton or vulnerable skeleton? Of course, if I'm going to do a closed reduction, I'm officially only interested in the extracapsular soft tissue blocks to the reduction, but also the effect that those may have had on my capsule and the hourglass constriction. My guiding principles are that hips should be in joint as soon as possible, AVN should be avoided, and the ossific nucleus may influence the timing of my treatment. And I think that a closed reduction, if appropriate, is better than an open reduction, but of course you may not agree. So if I believe that the hip should be in joint as soon as possible because of the concept of guided growth, then I should relocate this as soon as it is safe and practical to do so. And in my hands, that's from 6 months onwards. And our protocol is for a closed reduction with a short leg cast starting at 6 months of age. So we do an examination under anesthetic based on our pre-operative imaging. What am I expecting to see? I expect these two hips to behave differently. I expect one to be more ortolani positive and the other one to slide in a bit like a reverse Barlow maneuver. I then use a needle going in medially below the adductor longus tendon, aimed at the tip of the scapula, aiming for either the femoral neck or into the joint, depending on where my femoral head is. I inject 2 to 3 mils of Omnipaque. I use that then to define the anatomy and decide what sort of a hip I'm dealing with, and to think about what soft tissue blocks are preventing my hip from coming in. And most specifically, do I think that psoas is a problem lying across the front of the empty acetabulum? Then, does the hip reduce? Do I get the maximum diameter of the femoral head below the labrum? I don't mind having 2 to 3 mils of medial pooling, and I personally think that incongruency at this stage is perfectly acceptable. Once my hip is in, and I use that term lightly, then I want to know whether it's at all stable in that position. So not so much the safe zone, but a stable 3-dimensional cone. And I want to use that concept to decide whether I need to do any additional soft tissue releases through a transverse groin incision, just distal to the groin crease. So if with the hip in, I have abduction less than 45 degrees, or the stable zone between location and dislocation is less than 30 degrees, then adductor longus goes via an open tenotomy. If as I extend the flexed hip below 90 degrees, there is any suggestion on the arthrogram of instability, then I do an open psoas tenotomy at the level of the lesser trochanter. And then I get an improvement in my congruency and an improvement in my stability. So then I have to maintain the reduction in a good cast depending on what position. Officially, less than 60 degrees, but unofficially in gravity-assisted abduction with the hip flexed at 90, if not more than 90. We use a short leg cast because it allows rotation and we feel that this aids hip development. We check on progress with a scan, a repeat arthrogram at the 6-week mark. Total treatment time is 4.5 months because it takes time to guide hip growth. So our protocol is the same for both of these hips. One had a soft tissue release, the other did not require it. So on day 1, the hips looked like this, and at the 6-week check, there's been significant improvement in congruency, anatomy, and stability. Of course, we should avoid AVN, and we've discussed yesterday that there could be problems with the ossific nucleus. So there is still considerable controversy as to whether or not the presence of the ossific nucleus is going to protect the hip or not. So these two were closed reductions. Is one protected and the other not? Is it the presence or the size of the ossific nucleus? And are we looking at a sign of maturity or of structural stiffness? In our closed reduction protocol, which we're reporting shortly, all cases of severe osteonecrosis, the ossific nucleus was absent at the time of reduction. So perhaps it does protect, but maybe it doesn't influence the timing of our procedure. And finally, as a matter of personal philosophy, is this hip going to settle into joint, or is the pressure on that labrum going to cause harm and be a contraindication to a closed reduction? So would an open reduction be better? Yes, for certain hips, the TONIS 4 or the IHDI 4, or for a child over 18 to 24 months. But whatever your philosophy, you must know your results, and if they're not good enough, then you must do something different. Thank you.
Thanks, David. That was fantastic. But now Hamish is going to tell us why you're all wrong about that and why you should do an open reduction, medial or anterolateral.
Well, we've already discussed some of this in discussion, so I'll try and move through this quickly so we can have some more cases. My indication for an open reduction is if the closed reduction is not safely achievable. So if I need excessive abduction, if there's some ongoing instability, so we've got a failed closed reduction, or there's persistent subluxation of the hip. I think you really need to look for subluxation because it's bad, or obviously if you've got a dislocated hip. So do you choose a medial or anterior approach? Well, the advantage of the medial approach is there's minimal soft tissue dissection. It's a very direct approach to where a lot of the pathology is. There's minimal blood loss. You don't damage the abductors. Now, I personally find it very useful in non-DDH patients, for example, arthrogryposis patients who I want to get the hips back into joint very early. And I think following on from what Dr. Eastwood just said about taking psoas and the adductors, it's a very logical intraoperative progression from a closed reduction. So in my hands, when I'm doing a closed reductions, I routinely take the adductor. I almost always take the psoas tendon. That's my medial approach. If then I have any question about stability or obstacles to reduction, I can easily just continue that on and do my medial open reduction at the time. Doing that for a closed reduction every time also is a fantastic way of practicing this medial approach. The disadvantage is you can't perform a capsular plication and you cannot perform a pelvic osteotomy. The anterior approach is more familiar to most people. You get excellent access to the ileum and the acetabular rim, and you can do a capsulorrhaphy or capsular reefing at the same time to improve your stability. The disadvantages maybe are that the abductors are stripped. I haven't seen a problem from that, and sometimes you do have slightly more blood loss. So I want to illustrate these approaches with some examples. Here's a girl who's 4 months old, breech delivery, had bilateral dislocation of the hips at birth, was treated in a pelvic harness, but after 3 months in a harness, the left hip was still unstable. This is 4 months of age. This is early in my career. At 5 months of age, I did a closed reduction. I would now wait way longer than that. It docked nicely, and I think you should call it an EUA and arthrogram. The EUA is the most important thing in my hands, and I didn't appreciate at the time of this that this was actually unstable due to a deficient posterior wall. I got a post-op CT scan, and the hip was dislocated posterior after that closed reduction, so I went straight back to the operating room that evening and did an open medial reduction that night, deficient posterior wall. And the lessons that I learned was my EUA after my closed reduction wasn't as stable as it should have been, and I should have waited much longer before doing anything because of the pelvic harness disease. So it was open medial reduction was a logical progression from my closed reduction. So for a child under 12 months old, I do an open medial reduction. I won't go into details about that because I think most of you were at Dr. Winger's excellent discussion of that earlier today. But I use a Weinstein modification of the Ludloff approach, going just behind deep to the pectineus fascia, above the pectineus muscle, and straight into the medial aspect of the hip. I put them in a hip spiker for 6 weeks post-operatively. I don't do an arthrogram at 6 weeks, but they do have that change of cast under a general anaesthetic, and then they get a CT scan or MRI scan after that 6 week change of cast as well. So they're in a cast for a total of 3 months, and then the spiker is removed in clinic. They get an X-ray then. They don't have physiotherapy, but they're encouraged to swim, and then I review them again 6 weeks after that with a further X-ray. In a child who's over 12 months, like this patient with a high left dislocation and still a slightly dysplastic right hip, I want to do an open reduction, and I think we've discussed this at length, because I want to do a pelvic osteotomy at the same time, and I probably will usually do a femoral derotation osteotomy as well. I can only do this through an anterior approach, and therefore I'll wait till they're about 15 or 18 months. My open reduction involves, again, this is an anterior approach, but I take my psoas and adductor longus through my little medial approach. I then do an anterolateral approach to the joint, do a capsulorrhaphy, and excise all the obstacles to reduction. I do my derotation osteotomy through a standard lateral approach using a blade plate, as shown here. The osteotomy I use is just about always a Pemberton osteotomy. I don't think you want to over-hinge it or over-crank it down. I use the iliac wing or some femoral bone graft if I've done a little shortening, and I don't use fixation. Here's an example of the osteotomy going in and hinging that on the triradial cartilage, putting the bone graft in, and I think the result's satisfactory. Two things have influenced what I do a lot, and similar to Pablo, we've had some not what I'd call satisfactory results from doing closed and open reductions alone. So you can see that in Auckland, in 160 hips, we've got a redislocation rate of 15% following closed reduction in children, and we've had a reoperation rate in those kids of 26%, and the third operation in 7%. So I think this concept of perhaps waiting and doing an osteotomy, especially a pelvic osteotomy at the same time, is probably a good concept. And I certainly was influenced by Dr. Wedge's results, where when they looked at 2 cohorts of patients that had had a pelvic osteotomy had a much better long-term acetabular index than those that had just a femoral osteotomy and not a pelvic osteotomy. So in summary, knowing both the medial and anterior approach is useful in the management of DDH. I think in younger children, a medial approach may be preferable and easier if you're trained in it. In children greater than 12 months of age, I would consider an anterior approach, so I can do a pelvic osteotomy at the same time. But I think the take-home message is, if you're going to choose one, there's nothing wrong with just choosing and becoming very good at an anterior approach. Thanks.
Thanks, Haim. That was fantastic. Dale, could we have the cases 2 slides up? And that's going to conclude the actual talks. We do have a few minutes left for some cases. And if anyone would like to have any questions, please come to the microphones, or you can send them in through the moderator. Are there any questions from the audience? Yes. Simon.
I have a few questions, if that's okay, but kick me off when you've had enough, so I don't want to hold the microphone. Hamish, when you do an anterior approach, you do your psoas stenotomy through a medial approach. Why not take the opportunity to release it over the brim?
Yeah, so why do I do a medial approach as well as an anterior approach for my open reduction? The reason I do that is I like doing it. I find it easy to do, and I really like, once I've done my anterior approach, I can really make sure visually and with my finger that I've got the hip really well reduced. So after my capsulorrhaphy that I've done for my anterior approach, it also, I can get in medially and really know that I've got that hip well reduced.
Why not do an intramuscular tendon lengthening of the psoas over the pelvic brim rather than completely release it at the lesser trochanter?
So why not just do the psoas tenotomy at the pelvic rim? I totally agree. I think that's a way more routine thing that most people would do.
It's the scary bit, so I'm after you giving me a good reason why I don't have to do it anymore, and I'll do the medial approach like you're suggesting.
Yeah, I mean, I think if you have done a lot of medial approaches, you do it for the closed reduction, it's reasonably straightforward. I just like doing it there, and I can feel that hip come down. I know that it's really well reduced, especially in some of those really high, tough dislocated hips. Yeah.
Okay. One quick question for Deborah.
We do that question and we'll get back to yours. Is that okay, Simon?
I just wanted to ask about the use of the abduction orthosis, if anyone's before closed reduction using the abduction orthosis for failed Pavliks.
Okay. I think this next case will actually answer your question. 3-month-old girl, no family history, pregnancy was normal, but she had a positive Galeazzi and no ortholine, so a hip which was unable to be reduced. She was placed in a Pavlik harness, and this is how she presents to clinic after 3 months in the harness. And this is the ultrasound, so that hip is not going in. Chad, alternate bracing? There's a question over here.
Well, I mean, the bracing's failed, so I think that long they're going to have some Pavlik harness disease, and I'd leave them out of the brace for a while. As far as closed reduction is concerned, though, it is a matter of age at the time you do the closed reduction, the severity of the dislocation, and how long you keep them in a cast. And so, you know, Hattori had followed kids to maturity that he'd done closed reductions on. 85% of them required additional surgery, but he only kept them in a cast for a month.
Right.
So maybe if you take a younger child like this, attempt a closed reduction. This is one I would attempt a closed reduction on, look at an arthrogram, and if it looks really, really good, I'd put them in a cast and keep them there for quite a while.
So at 3 months of age, to answer your question, would anyone else use any form of bracing?
For this sort of a hip, no. But if it was an ortolani positive hip that was refusing to stabilize in a Pavlik harness, I would definitely use a more rigid brace, definitely.
Simon, what was your other question?
Deborah, after your closed reductions, you were putting them in a short leg cast. Yeah. I'd love to be able to do that. I'm sure it would be much more popular with the families if I did. But I worry that when they extend the knee, that hamstring tightness might push them over the edge in terms of instability. Am I worrying unnecessarily?
Well, we haven't done the comparison, which is the main criticism, or one of many criticisms against this study that we're trying to get published. We feel that the baby won't kick enough to really extend the knee enough. You know, it sort of will limit itself because of the tight hamstrings. But I think we do have a reasonably high initial failure rate. So we accept the hip, but then a few 13% come out within the first few days, and I think that will be, amongst other things, a bit of hamstring tightness. But we like the short leg cast because the hip really rotates, and I think it helps the docking procedure, and I think it helps acetabular remodeling, but we've got absolutely no evidence to back that up.
Thank you.
So this hip we took to the OR, and we attempted to do a closed reduction, and were unable to do it, but this was too young for me to do an anterior open reduction. That's the ones where I would do a medial one. And I don't do arthrograms because I don't think I gain anything from doing a preoperative arthrogram. You can see the physical exam. That makes much more sense to me. When I try my closed reduction, if this hip drops in and it's stable within a safe position, then I will leave it in a closed reduction. Otherwise, I will go to a medial reduction. And again, I think Dr. Wenger's talk on this was fantastic. I also use the interval between the adductor longus and the pectineus. You can see the medial circumflex vessels there. You need to be careful of those. I was taught that if you cut one of those, it was just a branch. If you respect it, then it was the actual artery. So I don't think you want to be getting in there very often. I agree you need to bring down the ligamentum teres, and I would never try and suture it to the medial aspect of the acetabulum. I would always excise it. And is that an acceptable, after an open reduction, is that an acceptable arthrogram?
Yeah.
Yeah. Post-operatively, who's getting MRIs and perfusion MRIs on these? Question, Will.
Presumably I'm assuming symptomatic somewhere, or
Well, if I could answer that, because I don't think it makes any sense. I think Colin Mosley has shown us that the ligamentum teres is stretched to a point where it isn't functional. It's not the center of rotation of the femoral head. This is not akin to reconstructing an ACL in the knee. From doing a number of revision surgeries, I can tell you the most consistent finding when you revise a hip is remnants of ligamentum teres. So it makes no sense to me, and we've actually scoped hips and found remnants of ligamentum teres which actually cause instability. Both centers who published that technique, doing it as a preliminary technique, which was San Diego and Australia, presented this as preliminary results. And neither of them have actually published their follow-up results on this. We're waiting for them to do this. But to me, it makes no sense doing it. I would prefer other methods of temporary stabilization of the hip. So I don't think there's any role for it at all. Panel, does anyone else think?
I agree. It doesn't make sense. If you get it tight enough to hold the hip in, then you've limited the rotation of the hip. But I want to offer a dissenting opinion about this arthrogram because it's not up against the medial wall. And there's, if you measure the distance of the thickness of the cartilage between the head and the ossific nucleus of the ilium, it's more than 3.5 millimeters, and this is a severe prognostic sign for later surgery.
Yeah.
So I think this child's going to have dysplasia later. I might accept that, but I would tell the parents that we're not through yet. When the child's 5, they're going to need some reconstructive surgery.
I would agree, which is why I think the next point was follow-up. Do you get an MRI?
We get one initially. Just
For what reason?
Just to confirm that it's
reduced. And then perfusion?
We're not doing perfusion, but I think it's a great idea.
If you did get a perfusion one and the head was not perfused, what would you do?
You would certainly take it back and readjust the hip position.
And it dislocates?
Well, then that's a good option for, then it didn't work. And so you wait till they're 15 to 18 months old and do a reduction.
So when would you do your perfusion scan? You know, within a minute, within half an hour, within, you know, when the baby's awake and be moving around a little bit?
No, I agree. We are doing perfusion. I don't think we know where that is yet. And I'll just jump through this because Chad showed this yesterday, and I think there's a role. Do you think you can do that MRI? Sorry to go through these a bit quickly, but we do have some more cases. If you do an MRI after a closed reduction, do you think there's any value to looking at these sort of MRI signals where you have this hyper-intense signal, a white signal within the labrum, which is a poor prognostic sign? Do you think there's any value in doing that as opposed to measuring the distance to prognosticate what the acetabular development is going to be? So if you did a closed reduction and you saw this, Chad,
that's a late, that's for determining late dysplasia, and this is only valid in a 3-year-old.
I understand, but do you think there's any role for that in a younger child?
No, not to look at acetabular development.
You don't think there's any MRI findings we could use, early MRI findings that we could use to aid in prognosis of acetabular development?
Hamish just talked about the cartilage acetabular index, but you know, I think you see that on arthrogram. So if you've done an arthrogram and you've looked in the joint, then I'm not sure you need it. Now, to decide if there's dysplasia, then an MRI can be helpful.
Okay. I think we don't know yet, but I agree with Debbie. I don't think we know where that's going to go yet.
Yeah, so I think you're right, Pablo. I think we need to be looking at those more critically. And I was in China not so long ago and learned a lot there about what their MRI findings are of the later dysplasia. So I think we should be looking, but I don't think we know enough yet to make it change our plans.
So I'll just jump forward and do a last case. This is case side by side, 21-month-old children, a boy on the left and a girl on the right. When's your threshold for doing a pelvic osteotomy? When are you going to throw in a pelvic osteotomy on this? What would your treatment be on this? Hamish?
So I think my main change in practice in the last 5 years has been way more aggressive at doing a pelvic osteotomy. And I think that reflects your experience, that you're more comfortable doing them. And so therefore I routinely do a pelvic osteotomy now from 15 months onwards because I'm really influenced by that paper by Spence and talking with John Wedge, who's had one half of those cohort of patients, that a pelvic osteotomy alone with an open reduction gives you a really good improvement in the acetabular index long term.
Okay, so quick show of hands. Would everyone in the audience, anyone not touch the pelvis on these hips? You get a good quality reduction. Everyone's touching the pelvis?
No.
Debbie's not.
Because this is another plug for catarrhalism, and I can only apologize, but the older I get, the more I think he is right on some of these things. So I think the pathology of the girl's hip is different from the pathology of the boy's hip. I think the girl's hip is likely to have been a true dislocation from birth. I think she's got a small acetabulum, which may not be that dysplastic, but it's small. The boy has got acetabular dysplasia with subluxation stroke dislocation. He's got much more abnormal femoral and acetabular anatomy. And therefore, I have to think about those two hips differently.
So would you do pelvic osteotomy on either of these?
On the right, on the boy's side, yeah.
All right, so my mentor, Dr. Cassis, thought the contrary and did an open reduction on the boy and an open reduction and a pelvic osteotomy on the girl. And I know some people might jump about the pins across the joint there, but that's actually been shown to be a safe and effective measure for temporarily stabilizing the joint. And if you see the follow-up on this, at 8 years of age, the girl did have some proximal growth disturbance, but the boy persisted with acetabular dysplasia. So at 8 years of age, do you think this was a missed opportunity to do something to that hip? Because nothing was done.
I think that's where your opportunity was missed, was at 8 years, because you can recover at 8 years. So as Hamish said, you know, you just are going to have a higher risk of secondary surgery down the road if you don't do a pelvic osteotomy. But if you watch them, you can still recover.
So you would have done a pelvic osteotomy here?
Bilaterally, after 18 months of age.
And you know, Ponseti wrote on that, if you go back, all those little dots you see in the boy's hip on the right, those little secondary centers of ossification are often a poor prognostic sign that maybe this hip was in there under pressure or something, but it's not. That's not a good sign. I noticed the girl doesn't have it on the left.
Yeah. So at 18 years of age, when I met these two patients, boy was dysplastic and had pain, and she was actually doing very well despite having this incidental finding of some form of cyst in the neck. But at 18 years of age, we did actually do a PAO on him and took care of the pain. But you need to do a lot more surgery, which could have been saved, I think, at that opportunity. So in a true Jack Flynn manner, it's being here, especially thank the faculty and everyone who was online on the webinar. Thank you very much.